All right, to all who are new here, my name is Dr. Michelle Henne, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedules, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenter and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on this website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly for any use of the video content, which is provided as is and without warranties. And we're looking for a sports medicine physician to join our team. It's a full-time clinic-based physician working in a sports medicine clinic. Please feel free to pass our information along if you know of a qualified candidate. For all athletic trainers intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customer care at gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. And so, as you may be aware, I will be your speaker this evening, and I will be talking tonight about the 2024 updates on PRP, platelet-rich plasma, applications in sports medicine. And so that is it was not intended to occur this month, but you guys had requested a speaker on TMJ, and unfortunately they had to cancel at the last minute. And so I went ahead and updated the PRP talk that I gave from 2020. The other fun thing to give my own little background and intro here is I will be returning from maternity leave on Monday back into the office full-time at Releve Sports Medicine. So for those longtime attendees who are familiar with our clinic, you'll see me back again in the clinic come Monday. So let's go ahead and let me make sure I am sharing my screen here. And yep, you guys have that as your view. Okay, to slideshow. Okay, so we are going to talk today. We are going to speak today about the history, the physiology, contraindications, indications, what the clinic day process is like, the equipment, the rehab protocols, and the economics of platelet-rich plasma. So we are going to cover all the same things that we had covered in 2020, but lots of updates. So just to briefly go through the history, it was initially introduced in the 1970s. At that time, they were using it in the hematology field. It makes sense because we're talking about platelets, we're talking about plasma, and that's where hematologists certainly specialize. In the 80s, we started to apply that same technology into maxillofacial surgery as well as cardiac surgery. And then by the 1990s is when we started using it in the orthopedic applications. So why platelet-rich plasma? We use it as an adjunct to conservative treatment. So this is to help when things such as rehab alone, exercise alone, anti-inflammatories in conjunction with those things have either been ineffective or intolerable due to persistent pain. It's also been utilized in scenarios when we're trying to avoid surgery. And so we were looking for alternative non-surgical approaches, and that's when we have utilized PRP. So what is it? What is platelet-rich plasma? So if we were to look at blood and break down blood by its components, you have plasma, which is effectively the water, although there's also salt and organic molecules in it. And then if you go from the smallest thing to the largest thing, you're talking about platelets next. So platelet-rich plasma is the component that we're talking about tonight. Something that has really come up from 2020 till today is the discussion on white blood cells. There are 5 different kinds of white blood cells, and what you're going to start seeing, if you hadn't noticed it already, is that there is leukocyte rich and leukocyte poor PRP. And so we're going to talk about a little bit of the evidence that has come out on that piece of PRP tonight. And then the largest thing in the blood is the red blood cells. Within platelets, why would we utilize platelets? Is predominantly because of growth factors. There's also interleukins and prostaglandins, but I'm going to talk here about growth factors. And so those are the endothelial, insulin-like, platelet-derived, transforming, and the vascular endothelial. And these are involved with collagen synthesis, bone maintenance. You're talking about osteoblast, metabolism. So you're talking about a variety of growth factors that are significantly and directly involved in the musculoskeletal system. So when we use PRP in vitro for human studies, and we'll get into specific pathologies in a moment, what we were finding particularly was with osteoarthritic chondrocytes, so the cartilage cells within someone who has osteoarthritis, and we found that PRP increased significantly the proliferation of those cartilage cells. We found that there was a dose-dependent decrease in inflammatory markers. We have seen that there is, and this was in total knee arthroplasty patients, so again, folks with osteoarthritis specifically, and their cartilage and their synovium were harvested and interacted with PRP, and we found decreased cartilage catabolism. So you had decreased amount of breakdown of cartilage, those catabolic properties, as well as inhibiting the inflammatory effects of interleukins. So we're seeing some of the protective effects to cartilage and decreased inflammation at a cellular level. Now, what are the contraindications to PRP? If someone has critical thrombocytopenia, meaning that they have very, very small amounts of platelets, if they have hemodynamic instability or septicemia, septic arthritis, cellulitis, or osteomyelitis. And those are conditions where certainly, it's really not the appropriate time period to be considering PRP. And you want to address those underlying conditions first and then stabilize them. And then if it's still if they still have an indication, you could certainly consider it once those have resolved. Now, relative, the most important thing relative that I always talk about in the clinic is related to anti-inflammatories. So there have been some very good studies that were done on the utilization of anti-inflammatories. This particular study was looking at aspirin, and it was published in AGSM in 2019. And it was looking at aspirin's impacts on those growth factors we were just talking about. And if the aspirin was discontinued for 14 days, we saw normalization of growth factor expression. There was another study done in 2019 that was on, from the Journal of Arthroscopy, done on naproxen. And naproxen required a 1-week washout period in order to return those growth factors back to baseline levels. So certainly there is something biologically appropriate to consider when people are taking anti-inflammatories, and ideally stopping those anti-inflammatories at least 1 week, if not 2 weeks before the procedure. For the same reason and the more potent concentration, you want to not utilize corticosteroid injections within 1 month of the procedure. Recent fever or illness, cancer, particularly of bone or blood. Now, why is that? The thought process there is if someone has a cancer in their blood and after PRP, you took parts of their blood, you injected it into their muscle, their tendon, their ligament, their joint. If that cancer were to be found de novo in this area that it was injected into, there's going to be a lot of finger pointing going on. So I certainly have no intention of doing it, and essentially require my patients to get oncology sign off if they have any, like if they have active cancer, or realistically any cancer that may be pertaining to those areas of the bone or blood. Anemia, thrombocytopenia. So we were talking about critical thrombocytopenia before. This is a relative thrombocytopenia. And then pseudo-gout, which is also called calcium pyrophosphate deposition disease. Why? Because PRP can actually cause an outbreak, an attack of pseudo-gout. So pseudo-gout is a weird misnomer. It's not pretending to be like gout. It's actually a totally different type of crystal, but PRP can cause a flare of it. And those are very painful. We don't want to cause them. So what are the indications? So let's talk about specific pathology here. So knee osteoarthritis, there's by far and away the most robust amount of literature coming from knee osteoarthritis. So we'll start first with the articles that we had mentioned in 2020, just so that you can see them. In general, there was a systematic review done. What it found was that at 2 months, the improvements were seen, and those improvements were maintained at 12 months. And this was comparing it to controls of HA and placebo injections. There's a meta-analysis done, and at 12 months, it exceeded the minimum clinically important difference. So there was another systematic review meta-analysis done, and again, these were fairly new studies. One was published in 2020. PRP combined with HA was more likely to reduce knee pain than PRP alone. Another meta-analysis found that it was most effective for those who are overweight or obese, which tends to correlate with knee osteoarthritis patients due to the risk that they have for development of knee osteoarthritis. And then they found that leukocyte poor PRP may be a superior line of treatment. So that was the first time that they really started talking about leukocyte poor versus leukocyte rich. Now, where have we come since then? So we have continued to do a lot of meta-analyses and continue to have randomized controlled trials, and have found a lot of the same, that overall pain scores as well as function scores of the PRP group have done better than hyaluronic acid, and certainly significantly better than steroid injections. We have also found more definitively that leukocyte poor PRP was better than leukocyte rich PRP. And this study is particularly as it pertained to function. What else? This was a study that was recently published last month it was from 2 groups at Mayo as well as HSS. And what they were looking at was the fragility index. And, it was really one of the first times that I've actually seen the fragility index come up in a study. And what it is it looks to see how many adverse events would be needed in order for the P-score, which often we utilize to demonstrate power, as well as the statistical significance of that study, in order to get that P-score to no longer be statistically significant. So move it from being less than that 0.05, which is the cutoff we often talk about in statistics, to above the 0.05. And so kind of a, almost like a statistics article that was being published here. But what they found was that the studies that are being done for PRP with knee osteoarthritis certainly have significant statistical significance, and within that, it's actually quite robust, so that you would need a lot of adverse events in order to change that statistical significance. In terms, the next condition we're going to talk about is UCL, partial proximal tear. So again, a recent study published a few days ago, a couple weeks ago, in arthroscopy, the Journal of Arthroscopy, and this was looking at the return to sport after UCL tears treated with PRP injections. And the interesting part, a couple things here, is the longer the people who had gone through longer rehab programs, so 12 to 14 weeks, their return to sport rates were actually quite a bit higher, and their I-squared scores, which looks at the variation, it was low there. They also were looking at the return to sports scores with leukocyte poor versus leukocyte rich PRP. And what they found is that the rate of return to sport for leukocyte poor PRP has a higher range, 73 to 100%, versus 52 to 88%, and a lower variation in comparison to that leukocyte rich. So we're going to get into those different types of PRP later, but I just wanted to bring that because another area where we're starting to get more finessed with how specific we are with that PRP. Now, one thing we do note here is right in the middle, that high heterogeneity has been observed. So we're seeing a lot of different quality studies here, and realistically, I'd say for UCL tears in general, this PRP for proximal partial tears has significantly been performed, but I would argue, it would be nice to continue to see more definitive data so we don't see as wide of a variation in the ranges. Partial or interstitial supraspinatus tears. So this is a prospective study done from 2016. The reason why I've kept this study in here is because it was one of the unique studies that was looking at MRIs before and after. And what they were finding is that there was actually tear volume diminution as well as greater than 50% diminution of the tear observed in a certain subset of these interstitial tears. So really, that being that it's a prospective case series, this is really quite interesting data that we haven't seen repeated again. So I would say that that's still quite relevant. This was a study looking, it was a double-blind randomized controlled trial, and they were looking at PRP with partial thickness. So the past one was interstitial tears. This is partial thickness as well as tendinopathy being seen. So at 3 months after the injection, the PRP group had significant improvement in pain scores as well as function scores. The American Shoulder and Elbow Surgeons, as well as at Western Ontario rotator cuff index scores. And then there wasn't significant outcome improvements seen early on. And interestingly, in this double-blind randomized controlled trial, we weren't seeing it at 12 months either. So it was like this intermediate range that people were doing well. There certainly was not a significant difference in the amount of the rate of failure, the conversion to surgery, so we were finding this sweet spot of improvements in pain and function in that intermediate zone. And then a more recent study that was done out of the Journal of Shoulder and Elbow Surgery was looking at the corticosteroids versus PRP, and this was a systematic review and meta-analysis. And in the short term, corticosteroids were superior. We've seen that frequently in that it helps to reduce pain in the short term. However, we were seeing recovery of function with the simple shoulder test and the ASES scores in PRP over steroids in that longer term time period. So hamstrings. In this first one is a randomized controlled trial. And this was, again, kind of flashback. We were finding that the return to play was shorter in those who had PRP as compared with control. And then, so what have we found more recently? The most recent study I could find was from 2022, and that one was slightly different than PRP versus physical therapy or rehabilitation alone. However, and what was that difference? The difference was that they were actually doing hematoma aspiration along with PRP for the treatment. So in this earlier time period, they were being treated from 2013 to 2015, they were being treated with physical therapy rehabilitation alone. And then from 2016 to 2018, they were having ultrasound guided hematoma aspiration done along with PRP injection into that partial tear. And that certainly can be done fairly easily if you're already in that location. And so what they were finding was that return to play time again was decreased. So it was 32 days in the conservative group, 23 days in the aspiration with PRP group. The recurrence was also less in the PRP group. Another interesting thing, particularly in some of those, say, soccer athletes, or I'm sure you have some athletes of a sport who they are just constantly re-injuring, re-aggravating their hamstring. So this certainly could be a consideration for those folks. Lateral epicondylitis, another common tendinopathy. Technically it's a tendinopathy, although we often still refer to it as lateral epicondylitis. No longer having inflammation, transitioning then into chronic tendon change. But this study is coming from 2023. That is a prospective triple-blinded study. And in this one, the scores were better in the steroid group at that short-term follow-up, and then better in the PRP group at the long-term follow-up. So you can certainly see that with these certain conditions, they were specifically selected because of some of the efficacy that we're starting to see with PRP. Plantar fasciitis is the next condition. And after PRP, this is another prospective study. I always certainly like those. I think those, when you are able to implement two different treatments and determine how effective that it works for these folks. In this situation, again, but only 25 patients, what we found after PRP infiltration is that their pain scores, those visual analog scale, scores significantly decrease at 3 weeks, 3 months, and 6 months, indicating pain relief, and their functional scores had demonstrated improvement. I would argue that if you did the meta-analysis, you may not see as much. They often have pain at that initial onset, but certainly in this very recent study that was published, they were seeing in those 25 folks pain relief, short-term as well as long-term. So if we look at it, PRP compared to corticosteroid injections, and this is a systematic review and meta-analysis. This one is from 2020. The PRP group had better pain scores at 3 months and 6 months, so better pain relief in the long run as compared with corticosteroids, which often lead to very short-term pain relief and frequently recurrence. So the next one is gluteus medius tendinopathy and greater trochanteric pain syndrome. So greater trochanteric pain syndrome being kind of like that trash bucket term. One of the pathologies that we find with greater trochanteric pain syndrome used to be called hip bursitis. Infrequently do we actually find bursas, but more frequently we do find that tendinopathy within the glute med. And so this was a double-blind randomized controlled trial with a 2-year follow-up. And what we were finding was that the leukocyte-rich PRP injection in this case did have sustained results at 2 years, and then improvement from corticosteroid injection was maximal around that 6-week mark, but certainly not maintained. So similar to what we were seeing in other studies, this was a 2019 article from American Journal of Sports Medicine. Next is going to be patellar tendinopathy. In this study, it was another kind of interesting study. They did dry needling alone, along with rehab, versus dry needling with PRP and rehab. And in this study at 12 weeks after treatment, what we found was that the pain score, this being the VISA score, Victorian Institute of Sports Assessment score, was improved in those who had PRP over dry needling alone. So then let's see, and coming on down, but that benefit seems to have dissipated over time. So at that greater than 26-week mark, we were finding that they had very similar function scoring. So a study from last month was this is a meta-analysis that was published on patellar tendinopathy. And what they found, they did a scale scoring, and it was assessing the general study quality that was being utilized within this meta-analysis. And what they found was that only 23% were of moderate quality, and that was about as high as it got. There was no studies that were considered high quality. And what they found, again, heterogeneity here, multiple PRP injections appear superior to eccentric exercises alone and provide lasting improvements. But again, some question on if we can continue to improve the quality of the studies that are being performed so that the meta-analysis can pull high quality studies. And what's that procedure like for those of you who have athletes who are going to have it done? It's typically a simple blood draw. And so we've been talking about leukocyte poor versus leukocyte rich. And I do want to, if I can send you home with one main point for tonight, I want you to start asking these questions of the physicians that you work with. What's their perspective on leukocyte poor versus leukocyte rich? So the Buffy code system has historically been the most commonly utilized system. Why is that? Because it takes less time. I would argue that's the reason why. It's a single long spin, and when you do a single long spin, you end up with this Buffy coat. And that Buffy coat has platelets. It's going to have many of the white blood cells. It'll actually also have some element of red blood cells, because the only way to pull off this Buffy coat and get as much of those platelets as possible, you're going to end up with some of that gradient that includes red blood cells. So this is the way, this Buffy coat system is a way that we typically and classically have obtained a leukocyte-rich PRP. Now, leukocyte-poor PRP, the plasma-based system, this arguably takes longer. So it has that may be one of the reasons why. I'm sure there's a variety, financial, whatever, that certain clinics have utilized the Buffy coat system, but the plasma-based system is where you have to do 2 spins. So the first spin is a shorter spin, and what it does is it leaves the platelets still immersed within the plasma in this top layer and pulls those white blood cells and red blood cells down to the bottom layer. And what you do then is you pull off that plasma and you put that into a new tube and you do a second spin where you concentrate that down. So where does the white blood cells end up? Predominantly the white blood cells are ending up with that red blood cell layer. And so this is how you would produce a leukocyte poor PRP. So does a platelet dose matter? So we were talking about white blood cells. So these are another point to make here, and this is looking at where are we going in the future. So we've been talking more and more about leukocyte concentration, leukocyte poor versus leukocyte rich, platelet rich plasma, but here platelet dosing. So this is a brand new study, again, coming out about a week ago. And what this looks at is a higher platelet dose may yield better clinical outcomes for PRP. This is specifically in the treatment of knee osteoarthritis, and this is a systematic review. And within this, what we're finding is that 5.5 billion platelets demonstrated a positive outcome. And if it was less than 2.3 billion platelets, there was not a positive difference noted. And so this was the first study really that we were looking to see, does the actual absolute platelet number matter? And when they had pulled these studies and identified, were they counting the number of platelets? And based on those number of platelets, were they correlating that with a positive versus a not positive outcome? Those were the studies that were included within this systematic review. What I included on the right is just a screenshot from Quest Diagnostics, one of the national labs. Why? Specifically to note what that platelet reference interval is. So we're talking 140 to 400,000 platelets. And so it really does require a very large concentration of a large volume of blood to be spun. This shouldn't be like a simple tiny little test tube of blood. You're really not going to get the volume of platelets needed to demonstrate that positive difference. So this is this is the first study that really has broken down and looked at what is the actual number that we need to do, and based that on a large volume of information. And ideally, in our next, let's say in another 4 years, if we do another update, I'm curious to see where, if we can finesse this even more. So maybe we pick a number that's between those two and fine tune that some more. So can patients modulate their PRP by activity? And so, as we get more information saying, hey, we need to have high platelet numbers if we want to have good outcomes, you're going to have more and more patients asking, well, how do I increase my platelet numbers? And if they have a reason to have thrombocytopenia, for example, B12 deficiency, folate deficiency, those things, you can supplement those to increase their platelet numbers. However, if they don't have a deficiency, it may not actually impact their platelets. So in those circumstances, then we one thing to consider then could be exercise. So it really, this article, it only took 20 minutes of vigorous exercise. And so I have a guy here who's, somewhat sweaty, who is exercising for that 20-minute period, trying to increase his platelets. And in this one, I have someone who is not nearly as sweaty, because what they found was that you can actually reduce that to a high intensity interval training, and it only took about 4 minutes to increase the platelet count. So rehab protocols, another area similar to what we were seeing with some of the studies that we are trying to improve upon and have more information to go off of. But this is a systematic review, and what we were finding is, as we looked at folks who had PRP injections done, weight-bearing restrictions were mentioned in about 12% of protocols. Orthoses were uncommon overall, 18%, and most common in Achilles tendinopathy protocols. The majority of the protocols instituted a period of stretching and strengthening, and that generally began about 2 to 7 days following an injection, and then stretching started about 2 to 7 days, and then strengthening started around 2 to 3 weeks. So if you are, and then that return to play was most commonly at 4 to 6 weeks. If you remember back to that UCL study that was looking at 12 to 16 weeks, so it's taking a little bit longer. So there is some consensus here regarding PRP protocols, but we don't have specific data to support why it is that we're doing our rehab protocols as we are. There's little known effect of those protocols, and we don't know if a different outcome might be different. Now, curiously, we do have some idea that maybe extending our PRP for UCLs to 12 weeks would have a higher return to sport rate. No studies directly compare protocols, one protocol versus another, and there's a lot of heterogeneity seen. And as someone who's part of the Practice and Policy Committee and on the AMSSM, American Medical Society for Sports Medicine Economics Subcommittee, I feel it's always relevant to talk about the economics. And so the appropriate price, this is kind of an interesting in my opinion, study that was done in 2020, was looking at what should we be charging for PRP that is the total cost to determine the utility gain per dollar and identify the price for PRP to be cost effective relative to hyaluronic acid in particular, as well as steroid injections, which it's easy to beat those, but steroid injections are very cheap, right? So you want, what this is saying is at what price is PRP going to both financially be effective, functionally be effective at the same time. So that total treatment cost would have to be less than right around $1,200 for 6 months, or $3,700 for 12 months, including the clinic visits, the procedures, and the injection. And what are people charging? And so again, in those studies coming from 2019, what we found was that the mean price, the average price for a single unilateral knee injection of PRP was $714. So you want to consider that if you are charging significantly more than $714, or the doctor's office that you are working with, you know, just kind of, it's a curious benchmark to have, and you can kind of find out where your physicians are falling as compared with that national average. Now, in terms of insurance coverage, at this point, the TRICARE does cover for PRP. And what's going to be interesting is that later this year, TRICARE is going to have to determine what they're going to do. Why? Because starting in 2019, they had approved PRP for provisional coverage, meaning this is how TRICARE operates. They will, if they're starting to cover something new, they'll approve it for provisional coverage for a typical period of time, and it can be up to 5 years, which is what they did here. And they specify it for certain conditions, so knee arthritis and essentially a common extensor tendinopathy. So those are the two conditions that they'll approve it for. And at the end of that 5-year period, they have to notify what are they going to do. And so here in a few months, in that third quarter, we're going to find out what TRICARE is going to do. And you know, granted, we had the shutdowns and whatnot in the midst of that, so maybe they'll give some leeway to extend it this one time. But I am very curious, because my expectation is that if Medicare is chatting with TRICARE about how much money that TRICARE is hypothetically saving based on this utilization, and Medicare decides to cover it, then a lot of the other commercial insurances will follow Medicare's direction. And then as those who are working with NCAA athletes as well as professional athletes, you're often utilizing insurances that do cover it, including AG administrators. AG administrators is also an insurance coverage for some of the NGBs for those that are involved with NGBs. So I want to thank you for your time. I hope this information is helpful for you, and I I'm already seeing some questions here. So the first question is coming from Michael. And Michael notes that I have an athlete that had to get PRP into her ankle. She couldn't handle the whole needle going in for the injection, so she didn't get the full effect of the PRP. Will she get any, she couldn't handle the whole needle going in for the injection, so she didn't get the full effect of the PRP. Will she see any benefit from the amount she got? Okay, that is a great question. And I would pose that the first question there, in my opinion, is actually what is her diagnosis? And Michael, you're welcome to respond if you happen to know that, because I would say, what are the scenarios intra-articularly in the ankle? I'm going to kind of, just assume that this was an intra-articular ankle injection that was done for a young person. By far and away, the most likely diagnosis, in my opinion, is going to be an OCD lesion, an osteochondritis dissecans, or an osteochondral lesion. Now, I'll tell you that with the foot and ankle orthopedic surgeons that I work with very closely and have on speed dial, what they have told me is that they have recommended in many of those cases where they have not appropriately responded to a period of non-weight bearing followed by a period of rehabilitation, they're having persistent pain, and that OCD lesion has not yet become unstable. They recommend that I perform PRP. Why? Because their perspective on it is that if they do surgery for an OCD lesion, that they often do not return to play. They're not able to get their return to sport percentage is actually very low. And so they feel that for some of those athletes that that giving them this opportunity of a non-surgical approach that may get them back to sport is an appropriate thing to try before pursuing surgery. Another situation where I've done it is I had someone a young person who had an ankle fracture and had significant hardware placed, so significant ankle injury, and they had hardware placed and then hardware removed. They were having persistent pain, persistent functional deficits. And so they were looking for an approach not necessarily to return to sport, but rather to improve their pain and function. And so they had pursued it and they did very well. And so Michael has given us additional information. So this is for a female pole vaulter, and she had a significant ankle ligament injury. And so she's going to need reconstruction after she graduates. Interesting. So then it becomes a question of, so are you going to be injecting around the ligaments? It sounds like maybe not. Maybe they may have been. So kind of an interesting case scenario here. If I'm putting myself into the shoes of the person who's looking at your female pole vaulter athlete, if they are doing it as almost like a preventive, they're trying to protect the cartilage, because if someone has a significant ankle ligament injury, and especially if they have multiple ligaments of the ankle that have been impacted, they are probably going to have some element of chronic ankle instability, which increases their risk of developing an OCD lesion or having an osteochondral injury. So in that scenario, it sounds like, if I'm kind of reading between the lines here, Michael, you want to protect the cartilage, but not take her out, because if she's going to have a significant reconstruction done later, she may or may not be able to return to sport after she's done that. And so we want to just protect this cartilage now and kind of put her down the road a little bit until her career has concluded, and then take her out and doing that reconstruction. So if that being the case, I think that can be certainly a reasonable consideration. in which case, then I guess your secondary. So I would agree that PRP is certainly an option in that scenario. Then your next question was tolerability, and that can be difficult. I mentioned that the post plantar fascia injection, post a tendon injection, those are ones in that PRP rehab where they talked about whether or not to utilize a orthosis or a non-weight bearing, an offloading type of approach. When you're injecting into tendons and you're injecting into ligaments, those tend to be areas that if you actually are into those structures, they tend to be quite painful after. So I often will offload them, and you are frequently talking about pain control, particularly in that first week. So I can understand, her not being able to tolerate it. Sometimes you try to do things like I'll tend to do nerve blocks to help in areas where I anticipate that it's going to be painful. The intra-articular ankle is kind of an interesting one that she found to be so painful, because the approach, if you kind of avoid the tendons and avoid certainly the dorsalis pedis artery, which of course is anteriorly, it's not one that is a painful one, but neither here nor there. So let's say, for example, she got a part of the PRP into the ankle, but not all of it. Then the question comes to, we have to take that data that we know, there's not a lot of great data. When I was researching it, when I had that ankle, the young guy with ankle osteoarthritis, what we can do for that condition is take data from the knee and apply it to the ankle. And at least in the knee data, based on stuff that came out, a week or so ago, what we know is that the higher the volume of platelets and utilizing leukocyte poor PRP is where we're going to have the best long-term outcome. So, if we don't know exactly what her platelet volume was, and we don't know how much of that she actually received, it might be a little bit tricky to say exactly, to anticipate how she's going to do. And the other hard part too is there's not nearly as much ankle data as we have for the knee. So I always tell people that's, kind of a little grain of salt there, is that there's less data. But good question. I like that you had that ability to have that in-depth conversation there with them. And so as I was kind of chatting along on that, there has been a lot of time for many folks if you do have questions. Otherwise, certainly if you do have other questions, you can always reach out to our journal club at Releve Sports Medicine and ask the questions there. And just wanted to see. Oh, you're welcome, Seth. All right, very good. So before I conclude then, what I would like to ask everyone is if you have speakers, and I know there's a couple of people who are attending tonight, and I reach out to you, if you have speakers, either speakers that you would like to talk just in general, you like them as a speaker, or two, you have a topic. If you have either a speaker recommendation or you have a topic recommendation, please let us know. Please let us know in the comments and the surveys, because I have really enjoyed actually some of the very unusual topics that you guys have requested. Things like jockey medicine, and we've had MMA, and just a variety of things that are unique. We do have a TMJ speaker that they're rescheduling just for a later time period. We have an obesity talk coming on next month. So we've got some good stuff in the lines, but if you have a speaker or a topic, please let us know, and we are happy to reach out to folks and find a good reach out to them on your behalf. All right, well, thank you very much, everyone, for attending tonight, and please don't hesitate to reach out with any questions, and I look forward to seeing you guys again next month.